Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, medial, occluding earwax and dry skin. So when we use the term medial, it's used to describe the depth of the wax, and in this case it's very deep. If the wax is more near the entrance, we would classify that as being lateral. And you can perhaps just see the floor of the ear canal adjacent to where the suction probe is. There's a bit of some soreness, some little scab there, and that's because the patient had been poking in their ears with their little finger, and the fingernail had abrased against the canal wall. You may also notice during the procedure that at times there's a bit of jerking, and that's just because during the procedure the patient was clenching their jaw. And when you clench your jaw, it contracts the muscles in the ear canal, and that causes the endoscope to almost be pushed out of the ear. So I'm fighting against that. And that can sometimes happen. People have different reactions when you perform earwax removal. When I've had someone in my ear before with a suction probe during a demonstration, for me, I close my eyes. It's just, and it's not painful at all. It's just my normal reaction. I just close my eyes. So the person performing the procedure is worried that they're causing me discomfort, and they're not. And I'm just, it's just a habit that I've got. So I kind of close my eyes and almost squint during the procedure. And in this case, the patient was just contracting their jaw muscles, but we managed to work with that. And just a bit of dry wax here with matted skin as well. And you can see the valley of the ear canal is extremely narrow here. So this region where it's narrow, as you can see, it's probably about the cartilage meets the bony part of the ear canal, and there's no known cause for it. The patient hasn't suffered from repeated ear infections, because if you suffer from repeated ear infections, you can develop stenosis, which is a narrowing of the ear. They don't report any exposure to cold water or wind, which can lead to surface ear, or also known as exotosis. And that's because the blood vessels on the bony part of the ear canal, in response to cold temperatures, the blood vessels dilate within the periosteum, which is a little membrane which separates the bony part of the ear canal from the skin itself, and it supplies both the skin and the bone the blood that it requires and the nutrients that it requires. The blood vessels, in response to becoming cold, they dilate, and that encourages bony growth. So they've not reported that. So it's possibly just anatomical, let's call it an abnormality, but in comparison to the right ear, this is definitely more narrow at the floor of the ear canal in the midsection. It doesn't look really like any prominent osteomas, which are spontaneous bony growths. You could argue there's one there about 2 o'clock. And when you've got an ear anatomy like this, it can sometimes encourage wax buildup, because the wax finds it more difficult to naturally migrate out of the ear. And the wax migrates out of the ear due to the skin that lines the ear canal. As that skin dies and sheds, it migrates sideways like a conveyor belt. And all this occurs from the centre of the eardrum. So the outermost layer of the eardrum is also made up of skin. And as that skin dies from the umbo region, which is the kind of the centre of the eardrum where the hammer bone attaches to, that skin ripples outwards and it creates this conveyor belt motion. So dead skin is naturally transported out of the ear, and any earwax debris sitting on its surface is also transported as a result out of the ear. But when you've got a narrowing like that, it can disrupt the migration of the skin, the epithelial skin, which is the skin cells that form the epidermis layer, which is the outer layer of skin. So this is their right ear. This wax is a bit more compacted, so I'm going to use an ear hook. There's an opening there. I've inserted it horizontally. I'm going to turn it 90 degrees clockwise, and that embeds the tip of the hook in and behind the wax and the skin. It just got lodged in the concha bowl, so I just used my forefinger and thumb to remove that from that region. So the majority of the eardrum's visible, but there is still some matted skin and wax at the floor of the ear canal, so I'm just going to peel this away. So this ear canal is a lot wider. It was the left ear that the patient felt was the worst ear. And that's because a lot of the wax and dead skin had been impacted against the eardrum, most likely because of their finger. Although, as I said, it's quite a narrow ear, so being able to push that in there, I suspect the patient may have used a cotton swab as well, potentially. I just don't think their finger would have fitted that deep in the ear. Certainly it could have fitted up to the point where they had braced the ear canal. You saw that a bit of soreness. So I've recommended they use some acetic acid spray. You can get it over the counter, especially formulated for the ear. That will help. Almost like a prophylactic heal, prevent a potential infection developing. When you graze the outer layer of skin, the epidermis, it allows an opportunity for harmful fungi or bacteria or even viruses to enter the dermis layer of skin, which is the skin protected by the epidermis, and that can lead to deep otitis externa. So we just want to prevent that from occurring by introducing some acetic acid. You're acidifying the ear, which helps prevent the formation of harmful bacteria and fungi into the ear. See, just a nice piece of skin just peeled away there. Textbook looking eardrum. I didn't have time to take any still images of the debris. I was a busy clinic, so I hope you don't mind. Hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.